Thank you. Thank you to the organizers for inviting me. I'm looking forward to talk to you about the AGP profile and how clinicians can get the best out of it. If you see the AGP report, it's quite straightforward, and I have been working with it for more than 10 years as a clinician. And to be honest, I didn't know there was something such as a structured AGP interpretation. And even without it, you can. It's very self-explanatory, so it's not really obliged to use this structured approach. But since I know that this exists, this helps me to get the consultation a little bit smoother, to win some time, to make sure I don't forget anything. And this structured approach, if I teach it to my patients and to my team, this empowers them to read the reports on their own. That's why I would like to give you a little bit more information about where the AGP report came from, where you can find it, also how you do a structured interpretation of an AGP report, and then some case examples if we have time. So I'm an endocrinologist from Belgium. I have founded Diabetotech, which is a non-profit organization where we give diabetes technology education to people with diabetes and their healthcare providers. So where does the AGP report come from? So in 2013, there was the first international consensus on how CGM data should be presented to clinicians to give a fast interpretation. So that was 2013. Then in 2019, you see the report as it is viewed today in LibreView. And at the same time, there was also guidelines on what the time and range goals were. And then the consensus, they keep meeting together, all these international experts. And the newest form from 2024 now has some more color data and some cleaner look in the top panel. But that is not implemented yet in all CGM reports. This AGP report is actually patented and licensed by the International Diabetes Center in Minnesota. But the good thing is it is adopted by most CGM firms. So if you look at a Libre sensor or a Dexcom sensor, you can view it in the same way, which is easier for us as clinicians. And this can be used for shared decision-making during office visits, where you compare the time and range of the person with their targets. So you can find it, of course, where you find the reports of your sensor, which has, here are the different data platforms. And I will show it to you for LibreView Pro. So if you make an account on LibreView Pro for free, you can connect your patients to it. You will have your patient lists. If you click on a patient, you can see on the first page when was the last data upload. So you should check if it was a recent upload. If not, you can connect your patient through their app very easily. And then you click on the green button, so it's very logical. And the first report in LibreView is the AGP report. In Dexcom Clarity, it's the last report. So how can you structurally interpret this report? The first step is to ensure that there is a capture of reliable CGM data. So it's recommended to draw a report of at least 14 days. Some clinicians like it more to have a report of 30 days, which is also fine. But if you draw a report of 14 days, you should have at least 7 to 10 days of data or 70 to 80% of sensor wear time. If there are gaps in the AGP, like in the AGP profile, it's that the person is not scanning enough. So if they do not scan before they go to bed, you will see a gap there. Or if you see missing data, you can address this problem and ask if there is a supply problem, if there is allergy, if there is loosening of the sensor, and help your patient. So if you have reliable data, how do you interpret the report? This is the structure that has been recommended. It's in 3 steps. It's determine, where to act, and it's similar to the 3 panels of the AGP report. So determine is the first step for the top panel. It's determine if action is needed, which is easy because if no action is needed, the consultation can move on and you can just congratulate your patient and motivate them to keep doing their best. So to determine if action is needed, you need to know the time and range goals. And the general time and range goals are showed on the left panel. And then you see the time and range of your patient. The mantra is strive for more green and less red. So more time in range and less time in hypoglycemia. And you can also mention to your patients that a 5% drop in time in range is already clinically relevant to motivate them. Time in range goals, if you look at the HEP report, you can see it's recommended to have a time in range of between 70 and 180 for more than 70%. But as you know, different people have different HbA1c or time in range goals. If you have children, for example, who have access to automated insulin delivery systems, or you have people with type 2 diabetes who are well regulated, maybe without insulin, you can strive for an HbA1c below 6.5. And in that case, you can strive for a time in range of above 80%. So this is the goal you can mention to your patients. Try to go above 80% if the HbA1c goal is below 6.5. And for people who their HbA1c goal is below 7.5%, for example, children who do not have access to AID systems and who have a high risk of hypoglycemia, they should strive for a time in range of above 60%. And if you have older people, frail people, where you say, like, my HbA1c goal is actually below 8%, a time in range of above 50% would be the goal. Here you see the publication of the time in range targets, which was published in 2019. And so you have the general time in range goal of more than 70%. For frail people, more than 50% is enough, with a focus on reducing hypoglycemia. And then you see the pregnancy ranges. In pregnancy, we strive for a time in range between 63 and 140 milligram per deciliter, of more than 70% if you have type 1 diabetes. If you have type 2 diabetes and you're pregnant, or you have gestational diabetes, you just try to get your 63 to 140 milligram per deciliter range as high as possible. There is no consensus yet on how high this should be, but you can take, like, in general, people take above 90%. And then more and more people are using CGMs if they don't have diabetes. And then it's a little bit more tricky. There is not a lot of consensus there. We do know, if you look at the time in range, this is not really clinically meaningful in people without diabetes, because it will be 99%. So it's better to look at the time in tight range, the time between 70 and 140 milligram per deciliter. In people who are healthy, this is normally above 95%. So if you have a person with pre-diabetes, the goal is to get that time in tight range, 70 to 140, or 54 and 140, above 95%. And if you see that the time in tight range is below 90%, it's time to check this person for diabetes with the general measures like blood function, HbA1c, or fasting glucose. It's important in this group not to look at the GMI, because if you have a well-regulated person, the GMI cannot be used for a diagnosis. So that's the first step. Look at the top panel if action is needed. Then if no action is needed, that's easy. If action is needed, then you can look at the HEP profile where action is needed. Here the mantra is go for a curve that is flat, narrow, and in range, very logical, and focus on hypoglycemia first, because a lot of times there's a problem of hyper, so many things you can look at. Just focus on hypo first, and then you already have one thing to discuss. A practical tip is to print out, is to ask the patient what do they see as a relevant pattern, to do this shared decision making, and also print out the HEP report. And what I also do is write down the units of insulin people take, especially if they are on basal bolus, and you can show to the patient, here and here I would do less or more. It makes it a little bit easier. There are also tips around CGM-guided nutrition, where you ask the patient, what did you learn? What did you see? Which kind of food did give some patterns? And then you can give some motivational suggestions, maybe try something healthier. And there are guidelines for the CGM-guided nutrition from the ADA recently published, and also some handouts to patients for people who want to use their CGM for CGM-guided nutrition. Again, start that the patient needs to know their glucose goal, their CGM targets, see patterns, see what lifestyle gives them peaks and glucose drops, and then act on that. Here is the act on that. This is the third step. And here, this step means that before you change anything, please look at the daily reports, see if there are trends, for example, especially in the weekends or on certain days, that you don't give the wrong therapy advice. So the next step, what I do is I scroll through the daily reports. And if you see some weird peaks and drops, you discuss to your patients what happened here, so you're sure you don't make the wrong interpretation. So those are the 3 steps, fairly simple. Determine where to act. The last thing, it's not really in the AGP report, it's in the device reports, but I included it because one of the barriers of CGM, if you have alerts, is this alert fatigue. So if there are alerts, I always check the alerts, if they're on, because some people put them off, and then if they are happy with the alerts, because if they're getting too much alerts, they're getting frustrated by the CGM for no use. So you should suggest to only set the alerts they're going to use. Right. I do have time for some case examples. So here you see a typical pattern of somebody with type 1 diabetes. You can see that the time in range is good, that far we are okay, but the time below range is 7%, which is above 4%, so here we have a hypo problem. So we know where we have determined that there is a problem, then we look where is the problem. You see that especially the hypos, there is a trend in the night that it goes down, so this is a patient where I reduce the amount of long-acting insulin. Here is a people with type 1 diabetes with a little bit of the opposite. The time in range is not 70%, so there is the problem. It's the glucose generally is too high. There is no problem of hypos. You see in the night it goes up, so I raised the basal insulin. This is a person with type 2 diabetes on basal bolus insulin, frequent admissions to the hospital. And you see the time in range is not in gold. So the problem is the glucose is too high, no problem of hypos. So where is the glucose too high? It's everywhere. So we do fixed fasting first. We raised the amount of long-acting insulin and then also addressed the problem of probably not injecting there at a meal or raising the dose. This should be discussed with the patient at lunch. And here you see a person with type 2 diabetes on oral drugs, and you see they have more insulin reserve, and you see it directly on the AGP profiles. They are getting narrower. So if you see a person with type 1 diabetes with these kinds of lines, or especially, for example, with the next kind of line, the smaller they get, you can see the type of diabetes they also have. So that sometimes gave me the feedback. So maybe this was not a person with type 1 diabetes. That's, yeah. Here is... So in this case, this person, the HbA1c, it's not noted here, but the HbA1c was 8%. So we were worried that she would need insulin. So we gave her a sensor and we saw that actually she is in range. The time in range was enough. There were no hypos. So we said, please do the good work, keep on going. And hopefully the next time the HbA1c also will drop. And we did not start insulin with this person on maximum oral anti-diabetic drugs. This was a person who is very old. She was very worried because in her care center, they measured the glucose late in the morning. So by the time she was having lunch, before lunch, and the glucose was always high, she wanted to have something to lower her glucose, but we gave her a sensor and we were able to assure her that her glucose was perfectly fine and metformin alone is good for her. Here is somebody with pre-diabetes. This is actually my father, like Dr. Partakar mentioned so well. What would you like for your loved ones? And he learned so much from a sensor. So it's really cool to give that experience to your loved ones and that they can learn a lot and try to prevent diabetes. This is an example from a study we're doing in gestational diabetes. So this person has late gestational diabetes and she's 30 weeks pregnant. She's already on insulin. And you see the time in range is very good, but of course we have to look at the time in range in pregnancy here. And a problem with LibreView is if you change the targets on the reports, it's not possible for the AGP report. It's only possible for the snapshot. So here we see the snapshot where you can change the targets to 63 to 140, and we can see the time in range for pregnancy is 90%, which is good, but there is not yet a clear consensus around the time in range targets for gestational diabetes. So it might need to be higher. We will see that in the future. So what we do now is we set the report on 63 to 120, so we can clearly see if 2 hours after the meal, the glucose is back to below 120, and we can see it if we need to change the insulin. So that was my presentation. For the conclusion, what is a structured AGP interpretation? It's ensure you have reliable CGM data, examine the AGP report in 3 steps, determine where to act, and check if the alerts are good for your patients. So I hope this can help you with your shared decision making and your consultation in a fast way, and teach your patients to do this for themselves, and also your team members to teach them to do this in a quick way.